1. Autoimmune hemolytic anemia. Definition. Autoimmune hemolytic anemia is the most common form of autoimmune hemolytic anemia characterized by the presence of autoantibodies that are activated at temperatures between 37 and 40 degrees Celsius. Had autoantibodies that attack red blood cells.
Autoimmune hemolytic anemia is a condition in which a person's immune system goes haywire and produces substances called autoantibodies that destroy their own. There are two types of autoimmune hemolytic anemias: cold autoimmune hemolytic anemia, in which the symptoms typically abruptly and resolve after some time, and warm autoimmune hemolytic anemia, which may develop gradually over time and persist for years. Autoimmune hemolytic anemia accounts for approximately 5% of all cases of hemolytic anemias. Amongst these, the warm antibody type comprises of 80 to 90% of cases, while cold antibody type occurs in 10 to 20% of people. The two types of autoimmune hemolytic anemia are differentiated based on the temperatures at which the autoantibodies stick to and destroy red blood cells. In the warm antibody type, the autoantibodies destroy red blood cells at temperatures equal to or greater than the normal body temperature. On the other hand, the cold antibody type is characterized by autoantibodies that are most active only at temperatures well below the normal body temperature. The symptoms of autoimmune hemolytic anemias vary with the degree of anemia and the type of anemia. People with minimal RBC breakdown have no symptoms, whereas others report tiredness, dizziness, shortness of breath, and a feeling of racing heartbeat. More so, when RBCs rupture, they release a red pigment called hemoglobin. This red pigment soon breaks down into a yellow pigment called bilirubin, which imparts a yellowish tint to the skin, eyes, and urine. Cold antibody type fingers and toes to turn purple on exposure to cold. The liver and spleen tend to enlarge because the destruction of red blood cells in AIHA takes place in these organs. Initially, the body tries to compensate for the loss of RBCs by making more red blood cells in the spongy part of the bone called bone marrow. But since the RBCs are destroyed too early at an exceeding rate, they become trapped at an immature, young stage called the reticulocyte stage. Elevated reticulocyte count is therefore a marker of all hemolytic anemias, including autoimmune hemolytic anemia. Blood tests can identify anemia as well as determine the cause of the autoimmune reaction. Some patients with autoimmune hemolytic anemia may need blood transfusions and corticosteroids or medications that suppress the overactive immune system, while others with more severe disease warrant removal of the site of RBC destruction, that is, spleen. For more information about autoimmune hemolytic anemia and a list of expert doctors, please visit www.expertdocs.com.
Applications in nursing. Control months. Explain the adverse effects of medicines. Monitor body weight every month. Check fluid intake, manage and delivery. Be careful with the skin and thus maintain an optimal balance of health.
Today I'm presenting an abstract about of this disease with new compounds, and in particular with a drug called APL2, which is a complement inhibitor. So the aim of the study was to assess the efficacy and the tolerability of this treatment, inhibition of the complement with a new drug to assess whether it can improve anemia and hemolytic markers in autoimmune hemolytic anemias. So we enrolled patients with cold and warm autoimmune hemolytic anemias in a phase 2 open label study with this subcutaneous drug, and we treated them sub-Q daily with either 200
Pros and cons. Pros. When autoimmune hemolytic anemia is caused by cancer, medications, or cold vascular disease, it may be enough to treat the disease underlying. Cons. In patients with active autoimmune hemolytic anemia, there is usually reticulocytosis.
Characterized by the body's own antibodies causing red blood cell destruction, a process known as hemolysis. Most cases are classified as either warm antibody, WAIHA, or cold agglutinin disease, CAD. The key differences are the types of autoantibodies involved and the temperature at which these autoantibodies are active. In warm AIHA, IgG antibodies improperly bind to self-proteins on the surface of red blood cells, activating the classical complement pathway, which causes C3b to attach to the cell surface, resulting in extravascular hemolysis, the destruction of red blood cells in the liver and spleen. In CAD, IgM antibodies improperly bind to self-proteins on the surface of red blood cells, causing them to clump together, strongly activating the classical complement pathway, which leads to the accumulation of C3b on the cell surface, resulting in extravascular hemolysis. In severe CAD, C3b activates the whole complement cascade, causing the formation of membrane attack complexes, known as MAC, which form holes in the surface of red blood cells, resulting in hemolysis inside blood vessels, called intravascular hemolysis. In a second hit, hemoglobin from destroyed red blood cells may overactivate the alternative complement pathway, increasing red blood cell destruction. Blocking the C3 protein may prevent complement activation and reduction of downstream triggers that cause hemolysis both inside and outside blood vessels. An ongoing clinical trial is assessing a C3 inhibitor in patients with both warm autoimmune hemolytic anemia and cold agglutinin disease.
It should apply in Ecuador. The disease can appear at any age and there is a slight predominance of 60%. Autoimmune hemolytic anemia is characterized by a hemolytic anemia. Conclusion. Autoimmune hemolytic anemia due to hot antibodies, it is more common in adult women than in other groups in immune disease, although it is usually idiopathic.